I wanted to talk about something that I don't want to say I consider myself to be like uh, a really great person at dealing with people or something like that. I think I'm pretty good. But this is something that I see sort of not messed up from time to time. That's the wrong word, but maybe not done as well as it could, or something that people express concern about doing. Um, or that folks really have never gotten any training or anything like that in. And that is, how do you tell somebody that their family member's dead? That's something that we should be doing in EMS, but not something that anybody's probably ever really kind of taught us to do, or given us any information on how to do. So you probably have heard a little bit of it. I think the number when it's been at least minimally studied has been something like 40-50% of people remember hearing about it in paramedic class. Essentially no EMT, no advanced EMT, and again, 50% of our paramedics have never really gotten anything on how do you tell somebody that you're going to stop working on their husband or their daughter or their wife. And that's kind of a shame, because we are constantly treading on that line. You know, we work on the edge of the abyss. Is emergency medicine and EMS. This is where we make our living. This is where we do stuff. And the fact that a lot of us we've only been trained for what to do, pick up and run, but never actually deal with the consequences of what we do sometimes, or the end result of what we do, which is sometimes sort of inevitable. That's kind of a shame. So I wanted to give you a basic idea of how to go about this, or the way that I sort of go about this. And I'll try not to belabor too many points here. Going back to that cardiac arrest algorithm, what should we be doing? You should have a field termination policy. You should not take every cardiac arrest to the hospital. You should not probably take most cardiac arrests to the hospital. The determination of death, termination of CPR, and the traumatic arrest protocol leave the open for that. The basis of what I think we should be doing in EMS: start more, do more, call more on the scene. Everybody that you can help, we should, and we should limit the risk for everybody that can't be helped. Here's a picture of me standing in front of this statement that you shouldn't work cardiac arrests if you're not willing to perform field termination of resuscitation. And not being able to perform field termination of resuscitation, I think, is probably unethical. And I can make the case for it if you really want. That is that providing a treatment, even if it is a relatively benign treatment, if there's minimal risk to the patient or to you specifically, if you're performing a treatment that has no benefit to the patient, it's unethical. And transport is a treatment, and we all know that. But this isn't something that just provides, that you just do and if you do it, no problem. There's no risk to it. Transporting somebody under cardiac arrest management is a really, not only dangerous thing, but a sort of sketchy thing to do, and probably does have some risk for the patient themselves. I'll get to it in just a second here. When you think about the benefit to most folks, if you look at the numbers, 25 or 30% of out-of-hospital cardiac arrests are going to get ROSC, somewhere in there. This is sort of standard data. Somewhere between 5 and 8% of those guys are going to ultimately live to whatever extent living is defined as. If you don't get ROSC outside the hospital, though, if you don't get ROSC in the field, the chance is under 1% that you are going to survive. So if EMS doesn't do a good job, if we don't do a good job in the field, if we don't get these guys back, the chance that they are going to survive is relatively low. Now, not zero, and we shouldn't be terminating all these folks, because certain groups have much better prognosis. But overall, if EMS didn't get you back, it's under 1% chance that you are going to come back. Now, you may say, all right, that's a lot of these guys, there may not be a whole lot of benefit, that under 1%, there may not be a whole lot of benefit in transporting, but what's the harm? We're going to pick them up and take them to the hospital? That's not going to cost anybody anything. Well, the harm is that you put this guy in an ambulance, you drive like a bat out of hell, hopefully not blowing through intersections, but even if you don't blow through them, even if you come to a full stop and it looks like everybody else is yielding, some joker comes around a car that has stopped and hits you head on, that's a risk. And that's a risk to you. That's a risk to the patient, I guess, for whatever chance that they had that you were going to get them back if you stood still. But that's also a risk to other drivers. Again, not sometimes it is not necessarily out of malice that somebody runs into an ambulance. They didn't see it. It's a blind intersection. They thought they had the right of way. They didn't know anybody else was coming, and they get plowed into, and people die in that way. So it's not that there is no risk. There's risk for the, to just coming out of, or to being out of service for that long too. And my pictures got kind of overlapped there. Sorry about that. Your out of service time that you spend hauling this guy to the hospital. Maybe if you're only, 6 minutes away from the hospital, it's not that big a deal. But if you have a 45-minute transport time, like some rural services do, or nobody's going to fly this guy, hopefully. But if you take somebody out of service for 30 minutes, or if you take two crews out of service for 30 minutes, or if you have an engine company that's with you and you haul all those guys in, and you take you and the engine and maybe a supervisor out for 30 minutes to an hour going to the hospital, where you could have stopped your resuscitation, left one guy to hang out with the family and wait for the coroner, or even just leave him with the cops. That is probably a better way to go about it, at least in terms of resource management, rather than tie up all those folks for a futile resuscitation. Now, I'm not saying that, again, everybody is, that we should terminate everybody on field and we should never do cardiac arrest, because we absolutely should, because some people will survive. And there is some stuff you don't have in the field that you do have in the hospital. But when you get them to the hospital as well, you're taking up 30 minutes of ED bed time. You're taking up, and nobody cares. I know pre-hospital providers probably don't care about that too much, but when you consume a doctor, 3 nurses, a tech, and everybody else that's in the department, that is for a half an hour, like that's a lot of time. And that really can kind of mess with the way things go otherwise. And there may be other patients who have a better chance that need some interventions right now that you're not able to take care of because you're dealing with this, what ultimately is a futile cardiac arrest. So start more, do more. Don't forget too that there is a risk to the patient. Trying to move a patient under cardiac arrest care, under CPR, even with a Lucas device, it's very difficult to do. And so you are probably doing them a better service to stay where you are, where you're able to do the better resuscitation. Stay where you are, do a good job where you're at. And if that's not going to work, then don't expose them to the risk that they are going to get lousy CPR, not get paid attention, they get extubated. If it's going to work, then it's going to work where you're at. The transport itself is not likely to be super helpful. If there is no benefit, then don't expose them to that risk. And finally, you have the risk of, I don't want to say creating a brain dead patient, but creating a brain dead patient. And depending on your view on life and what life means, some people say, well, life in any form is worth it. Okay, I can't really argue with that. Most of us would say there is definitely a limit to which I would want to have my life prolong. And if I'm not able to see, speak, if I'm terminally unconscious, have no blood flow to my brain, but my heart keeps going, I don't really consider that life. That's the feeling of many, many people. It is easy to get your heart restarted relatively. It may not be easy to get your brain back though. And that is the risk that we run with a lot of these folks that, yes, an hour of resuscitative efforts, we may be able to get your heart going again. The chance that your brain's going to come back is relatively low. And then you put the family in the position of, this is there hope? Should we keep holding out for hope? This has been an hour-long resuscitation. Is there any chance that grandma who's 80 years old is going to come back with any reasonable amount of function and a life that anybody would want to live? Probably not. But now what do? Do we just terminally extubate her and see what happens? Do we send her to a respiratory care center forever? These are all the problems that come up. And again, if there's no benefit, if there is essentially nothing that you can do to help this person regain a reasonable amount of life, most people would probably say, I wouldn't want to continue them. Anyway, we should be terminating in the field is what I'm kind of getting at, and I'm dwelling on it. Start more, do more, call more, help everybody that you can help, and limit the risk for everybody that you can't help. Once you've done that, we usually focus just on the patient when we do this cardiac arrest stuff. And that's cool. There's a lot that we have to do. We're sort of limited in terms of hands. Right at the moment, we got to do a whole bunch of things to this gentleman to try to get him resuscitated. However, as soon as we've determined that we've done all we can for him, all of a sudden, all the other patients, all the other folks that we can do stuff for become more apparent, and we need to turn our attention to them. That's a really hard thing to do, because the first thing we've got to do for most of the time when we've determined there's nothing else we can do for somebody, our first meeting or one of our early meetings with this guy is going to be to hit him as hard as we can, and basically sock him in the gut by telling him that his loved one just died. Now, I will argue that that is probably something that I would be happy to do for folks, because it is something that has to get done, and I want to get done in the right way. But it is a hard thing to do. And it is tough when your first interaction with somebody is to absolutely break them apart. So how do we deal with that? Well, number one, you got to recognize what's happening. Most of the time, our interaction with folks is going to be something like this. From an EMS side, it's going to knock you around a little bit, but then you're going to go back to the station. You'll have lunch, you'll have coffee. Maybe that evening you're starting to feel a little bit better, even if you're a little bit, even if you don't feel great to start off with. Most of the time, we're kind of able to move around after we get jostled around a little bit. That's us as providers. For the family, though, because they don't do this every day, because your grandma only dies one time in front of you, it's more like this. And we do have to recognize that our feeling on it is going to be quite a bit different than their feeling on it. And rationality after something like this happens may completely go out the window. So bear that in mind. I think it is really important to bear with this, that everybody will experience this a little bit differently. Maya Angelou said, I've learned that people will forget what you said, people will forget what you did, but people will never forget how you made them feel. And that's absolutely true. People have no idea, like out of every death notification I've done, I am confident that the person does not remember what exactly I said, but they remember about how I said it and what the thrust of it was, which is that I told them their son, daughter, father, mother died. They don't remember the text of it at all, or what exactly I said, or what exactly my words were, but they remember how I made them feel. Even if they think they remember what exactly I said, but nobody does. We should make a distinction here between like breaking bad news and inviting the family in to be present during a resuscitation. And I will say they are a little bit distinct in that there's sort of two ways to go about it. Number one, everybody needs to be able to break bad news to somebody, because you're going to have to do it. That is something that we have to do, and every family, you have to be ready to do that. If you are doing a resuscitation, you have to be ready to tell the person that this resuscitation is futile and we can't go on any farther, presuming that's in your protocols, which it absolutely should be. You have to be able to do that. The family presence during resuscitation is a little bit different, though, in that it's not something that every family wants or needs or something like that, but something that we should be able to offer. This, something you have to do, that, something you should do. So I will tell you that I think it's actually easier to do the second part if you've invited the family in and they've taken part in the resuscitation to whatever scope that they can. Sort of brings me to my next point. If you're going to do a death notification, don't let it be a surprise. Hopefully the family knows ahead of time that things are not looking well, and it's about time to kind of terminate this futile resuscitation attempt. You can help that by inviting them into the room, though. If you see what EMS folks say versus what, sorry, my animation got a little bit strange there. I was not expecting that. If you look at what EMS folks say, reasons that they wouldn't invite somebody into the family, or emergency medicine folks, what do they say? Well, it's going to be hard on the family. They're going to see us, and they're going to see us mess up, and then they're going to sue us. They'll get in the way. We can't talk like we normally would. We can't interact like we normally would. They're cramping our style, which is whatever. I don't have another person to dedicate to the family. And if we do something wrong, they're going to know about it. And I wouldn't want that to happen to my mother. I wouldn't want to see my mother in that state. I don't want them to see this person in that state. And finally, that they won't understand. When you actually look at what families say, though, they say, well, I got satisfaction from the support that EMS gave me, because they stood by me and they talked me through it. And that was helpful. They often say, we're comforted by how much everybody worked. We could really see that everybody was doing their absolute best in the resuscitation. They may say, yeah, we knew more about what was happening. It wasn't a mystery anymore. We felt closer to Dad because we could be present and make sure that everything was done and he was treated as best we could. We're glad he could die at home. It helped us adjust to the death process. And finally, a lot of the times people will tell you, we knew he was dead when we called. This wasn't a surprise. We knew it was coming already, and we are glad that we got to hang around and be part of it and be with Dad in his final moments, even if his final moments may have actually been a while ago. That's what gets attributed to it. Overall opinions on it. Not many emergency workers tend to have a favorable opinion about the family coming in the room. I think it's just fine. But only about a third of emergency workers probably have a favorable opinion. However, probably 2/3 or more wanted to witness their own family's resuscitation, which is about what other families say. But usually about 2/3 of the time, folks are willing to come in and see the resuscitation itself. Again, looking at families, of families that chose to come in, when surveyed, 100% of them said they thought it was helpful. When they were asked, do you want to go back? They said yes. None of them regretted going back. When asked again in big RCTs, about 67% thought that it would have been helpful if they could have gone back, which is that same number. About 2/3 of folks will want to witness their family's resuscitative efforts. And a big important thing, family members pay more attention to the support that you get from staff rather than for the actions of the staff. Really not many people are actually like out there critiquing everything that you're doing. Overall, families want the option to see this happen. And those that do choose to see it are almost overwhelmingly positive about it, and it makes it easier on them. And most people are not worried about what it is that you're doing if you are talking them through it, if you're explaining the stuff, and if it's not a surprise. Notification of death should start while the resuscitation is going on. This shouldn't be a surprise for anybody that suddenly you walk out and, we're done. Everybody just stops and throws their hands up. We need to make this a sort of process thing. So what are the keys to that? Number one, you need to be technically excellent. This is Seattle. You'll see these guys come in. It's all choreographed. It looks good. You need to know your stuff. And that's just part of being a really great provider. You need to be technically excellent, not just to show off in front of the family, but because that's for the best thing for the patient. You know what you're doing. You can't look like you're some guy that just rolled in off the street and picked up a med case and started giving the drugs out of it. So be technically excellent. The next part, work the family into your algorithm in one way or another. We have, the ACLS stuff spelled out here. Nowhere in there does it really tell you where to start talking to the family. Here's what I would do. First of all, of course, acknowledge the family when you first get there. But if the person's in cardiac arrest, you got to do a bunch of stuff real quick. Jump in there, start doing chest compressions, get pads on the patient, give them a shock, do some more CPR, maybe give a second shock. And then at that point, it's time to say, wait a minute, let's talk to the family a little bit here, because you've more or less gotten things headed. You've gotten the train started. Things are going to be on a little bit of an autopilot for at least a little while. You've got shocks delivered. You know what everybody's going to do. You've given your first round of drugs. You got 5 more minutes before you really got to do something else. Take that time and go talk to the family. And I would do that again after the second shock. It's good to acknowledge them to start with. Again, say, hey, I know, and everybody's good at this. Everybody knows this. If you have somebody to go assign to stand with the family, cool. They can talk, they can get history, they can get all that kind of stuff, and they can also talk the family through it. If you don't have that person, though, make sure that somebody after a second shock or about the second round of CPR, make sure somebody is talking to the family, find out a little bit more about them, but also let them know what's going on. And I usually say, I'm Dr. Lubbers. It's really busy right now. We're having to do a whole lot of stuff. I'll be back to talk to you more in a couple of minutes, okay? You can stand right there. I'll be back and talk to you a little bit more. I just can't right now. Now, at that point, you're going to repeat what you're doing a number of times, however long it is. Is it 20 minutes? Is it 30 minutes? Do your resuscitation. Be mindful in the resuscitation that there's family there, but do what you're going to do. Do your thing. At some point here again, though, when you get to about 20 minutes in or 30 minutes in, whatever your time limit is, now that you've got plenty of people kind of hanging around and doing more or less rote things, now's a good time for maybe this person or whoever your officer or your supervisor, or maybe even it's the paramedic, you can hand the bag, you got him intubated, hand the bag over to somebody and say, I need to go talk to the family. This is your chance to do the shot across the bow. You should not show up to the person if they are hanging out and just say, he's dead, and that's the end of it, or do it in a nice way even. We need to give him an idea that things are not going real well, and that we are about to the point where we're not able to help him anymore. Here's the way that I usually kind of do it. I usually go in and say to the family, I'm Dr. Lubbers. It's nice to meet you. I don't know what you've known, but basically we're doing CPR right now. Things are not looking good. We've done almost everything that we know how to do, and we still haven't been able to get his heart back, and we haven't gotten him to breathe on his own again. So we are running out of things that we can do and ways that we can help him. But I want to give you a second to see him and talk to him before we actually stop. And people respond pretty well to that idea. And many times folks that did not want to come in and witness the resuscitation before that may change their mind and say, okay, yes, I want to go see mom, dad, whoever. This is the time to give them that opportunity. Again, where do you include that in here? I would include it before your termination of resuscitation stuff. I would say it is a requirement that before you can make a medical control call if you want, or anything like that. But when you've met all that criteria, all that stuff that you would do otherwise, I would say before you actually stop, you need to go talk to the family, and somebody needs to tell them that essentially he's not going to make it, or we're about to stop, but I want you to be able to talk to him before we actually stop our efforts. And that works out, again, pretty well. Many people will change their mind and say, yes, I want to go see him at that point. And that's a pretty good way to go with it, if you ask me. Now, at some point, you're going to have to drop the bomb. Things have not gone well. You've been doing CPR for 30 minutes on this 88-year-old male with history of dementia and end-stage cancer, who for some reason doesn't have a DNR. Family is hanging out outside. Family's hanging out in the hallway. At some point, you got to actually tell them that we're stopping, or that you have stopped and that grandpa has died. Remember, again, the important thing is not so much the words that you use. It is how you made the person feel when you go out to do it. So I will say, before you go and make that effort, you get one shot at this. You only get to tell somebody one time that their mom died. And so you need to be ready. So when you are getting ready to do this, I clean myself up a little bit, tuck in your shirt, take your gloves off so that you can put a hand on a shoulder or something like that. Make yourself kind of presentable. Think about funeral directors. Have you ever seen, funeral stuff? Death care is a really industrial process, really, when you look at it. But have you ever seen those guys working without at least a shirt and tie? Pretty uncommon anyway, because that's the expectation. So make yourself look kind of presentable, wipe the sweat off your brow, put your hat on if that's the thing, so you can take your hat off, fix your shirt so that you're not looking like you just ran a marathon or something like that and you're all disheveled, because the presentation does make a bit of a difference. It's not the most important thing, but it will help. And as I said, take your gloves off because you want to be able to talk to the person, and you're about done. There's nothing else you need gloves for right this second anyway. Don't go until you're ready. But when you're ready, do have a plan. I'm not telling you to use a mnemonic. I really don't like mnemonics. This is an okay one, but do you remember what the G is going to stand for? Do you remember what the R, or how about there's two I's? Which I stands for which one? Do I inquire first, or do I identify first? I put this up here only as a template to say this contains most of the stuff that's probably good to tell somebody when you're going to break bad news to them, not to tell you that you should use this and go by it every time. I will say it hits the high points, but what I would recommend is that you figure out some script. If you've not done this commonly, if you're not exceedingly good at this and have a scripted sentence that you're going to say, that you develop that script and then you practice it over and over and over. Practice it in front of a mirror, just practice it laying in bed at night. Come up with something that meets these points, but then you can rattle off without really having to think about it. Because that is the way that you'll get this stuff done effectively and not trip all over your words. Let's hit them real quick. This again, the grieving mnemonic. First, gather interested parties. You don't want to have to tell somebody. You don't want to have to repeat this 3 or 4 times for the same patient. It's hard on you. It's super hard on the family. So everybody that is around, anybody that needs to hear this, gather them up kind of now. Also identify before you go and actually do the deed. Figure out what resources can help you. Is there a chaplain on the way? Okay, if there's a chaplain on the way, then maybe we can wait 5 minutes and we'll just continue to kind of slow code this person. Is there a family priest? Is there somebody that can help us otherwise? Do we need a translator? Ooh, my God, that was the worst thing I've ever seen, is trying to deliver to a Spanish-speaking family news that their baby had died through a translator. And luckily we had somebody on the fire department who could help us, who was fluent in Spanish, so we didn't have to wait for somebody to come in. But gather those resources ahead of time, figure out who can help you. After you've gotten everybody together and you've gotten your resources together, you can approach the family. Start by identifying yourself. Certainly to anybody that you haven't identified yourself to already. The makers of this mnemonic also identify that you have bad news. The family kind of knows that already. I don't think that really helps. The shot across the bow should have been done a while ago, and that this is something bad is happening. Telling them that they have bad news only leads them to think, without confirmation immediately, they think the worst. And usually people will break down when you say, I have bad news, and somebody breaks down and then they stop hearing you altogether. I say, identify yourself. Hello, I'm Dr. Lubbers. You're Mr. Smith's family. You're his wife. Okay. Figure out who each person is. Shake their hand. And then they say, educate survivors. Give at least a very brief background on what's been going on. He's very sick, so bad that his heart had stopped working and he wasn't breathing. We've been breathing for him and giving him medicines to try to help him, but we haven't been able to get his heart to start again. We did all, and then verify that he has died. We did all we could, but we couldn't revive him, and he died this evening. Now, that he died this evening is a very important thing to say, and I like to phrase it that way to make sure that there is no question that, he was, dead early this morning or something like that. This basically hits the person with it quickly and gets it over with. Now, you may say, well, that's kind of terse, and that's true, but I'm not going to tell them this and just walk away. I'm going to pause. This is the pause for a while. And I'm just going to let whatever happens in that time. If the person falls on the ground, I'll, be with them. If they cry, if they scream, if they punch the wall, I'll be around there. But I'm not going to say anything and just let that all happen. At some point, it's going to be important for you to say, do you have any questions? Can I answer anything? And sometimes people have questions, sometimes they don't. But it is definitely worth asking. I never say, I know how you feel or something like that. I would say it must be very hard to think right now, but is there anything that I might be able to answer? Maybe the answer is no. But often they will say, can I go see him? And that's when you identify the nuts and bolts of what happens next. Well, yes, you can see him. We've got to call the coroner, though. As soon as we get notification of that, you can call the funeral home, helping to figure out what the next thing is, because most people haven't experienced a death in their home or a death in a public place or anything like that, and they need some guidance. So you say what you say exactly what we're going to do next. We're going to clean up our stuff. We need the police to come, and we need to talk to the coroner. And at that point, they can call the funeral home or whatever. But make sure you know things like resources, and well, who do I call? Well, I don't know. Good luck. Try to be try to give as much information, as much help as you can at the time. That was sort of a manufactured way to go through that. And the way I would do it is the following. And I have a script, and here's what I say. I walk into the room. Let me take this off of there. I walk into the room and say, hi, I'm Dr. Lubbers. You're Mrs. Smith's wife? Yes. Hi. Hi, you're your son. Hi. Hello. I'm the doctor taking care of Mr. Smith. I don't know what you know, but when he came to us this evening, his heart had stopped and the paramedics were doing chest compressions and CPR on him, and he wasn't breathing. We've given him medicine and tried to breathe for him, but we haven't been able to make any progress. And he is sick enough that I think he is basically beyond what we're going to be able to do to help him. This is, again, assuming that the arrest is ongoing at that point. But I want you to have the opportunity to go back and see him before we stop doing everything. And you can see him and talk to him and touch him. That's what I do if the patient is still undergoing kind of resuscitative efforts. If it is just a death announcement, like we called it 5 minutes ago, go something a little bit different. Hi, I'm Dr. Lubbers. You're Mr. Blah, blah, blah. again, I don't know what you know, but this morning when he was brought to us, his heart had stopped and he was not breathing on his own. We've done everything we could for him this morning, but he was so sick that we were not able to get his heart to start again or him to breathe again. And unfortunately, he died this morning. Pause, 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 pause. Patient, and again, the family usually does something at this point. But that's all there is to that part of it. That's really hard to kind of get yourself to say sometimes. But I think there are some really important things to kind of mention with these. And I've done, again, a number of these. I don't pretend to be an expert or anything like that, but here's the keys that I've got. Number one, once you start, I don't know what you know, but he was not breathing and his heart had stopped beating when we saw him. Once you start saying that, somebody often will try to interrupt you. Well, is he okay? Is he okay? Nicely continue on with what you're saying, because you've only got like 2 sentences that you got to say. His heart had stopped and he wasn't breathing. We tried everything that we could, but he died this morning. You've got to get that out. And there's no reason to kind of stop in the middle of it and say, well, he was not breathing. Don't waffle around it. Here it comes. There is no reason to let this person kind of suffer like this. Go ahead and deliver the news quickly, and don't be distracted by other actions in the way. Don't take this time to explain. Don't say, we defibrillated him, we gave him a bunch of epinephrine, we placed a chest tube, all this kind of stuff. You're summing that up already. You've said we did everything we could for him, but he died regardless. Now, if there's some explanation that you've already given, if you've started a relationship with a person, like that's perfectly fine, but there's no reason to explain all that stuff. And certainly don't use terms like, again, defibrillate, gave epinephrine, started a line, something like that. There's no need for that now. If the family's curious, they'll ask you later, but you don't need to explain that to them now. Just say, we did everything we could, because that's the truth. And if you didn't do everything you could, then, well, you got some explaining to do to somebody else. It is important to say that he died today, or she died today, or Mr. Smith died today. Pass on doesn't help, because he didn't pass on. He died. He's dead. You need to actually say the D word, because otherwise, there are some times when people say, "Well, is he going to get better?" It's like, no, he passed on. Well, is he okay though? You need to say that he died. There is nothing, you can't sugarcoat this. There is no way to sugarcoat it. The person is dead. And that information has to get out there, and trying to use a euphemism for it doesn't help anybody. He died today. After that, I usually say, and people have different opinions about it, I usually say, it is fine to be sorry. He died today. I'm so sorry this happened. Because I am. I'm not sorry. I'm not apologizing for something I did. People die all the time, and we try our best to make it better. It doesn't mean that's not an admission of culpability or something like that. If you're not sorry, like you're some kind of monster, to some extent, or at least people will think of you as that way. You just saw somebody die. It is fine to be sorry, and it is fine to say you're sorry. You're not apologizing for something you've done. You're sorry that this person is sad, that you just had to deliver this terrible news to them. That all should make you sorry. And it is fine to say that. And there is no admission of culpability or anything like that. Even if something went terribly wrong, you saying, I'm sorry for what happened, or I'm sorry that this happened, that is not you saying anything bad. So I like to say I'm sorry. If you can't say it genuinely, if you just say like, oh, I'm so sorry for your loss or something like that, I think that sounds kind of disingenuous in this point. If you can't be genuine about it, just don't say it. That's fine. You don't have to say you're sorry. But finally, again, I'm being sort of terse with this stuff. Don't walk away. I can walk in and deliver those 2 sentences. And yes, I'm not going to pussyfoot around anything. It is going to hurt a lot. But then I am also not going to go anyplace. I'm not going to immediately turn around and walk off. I'm going to stay with that person until I'm sure that they are okay in one way or another. Because the patient's already dead. That's happened. What I want to do is make sure that the family, who is the one group that I can help, is going to be okay. And the way that I can do that is just by physically being present. If they are in the room, then you may want to say, yeah, you can see him. If it's an expected death, yeah, you could hold his hand. you can talk to them. That sort of stuff is fine. Obviously, if it's suspicious, if it's a crime scene, the police are probably hopefully going to be there already, and will kind of help guide whether or not that's okay. But encouraging the family and going with the family when they're going to view the body, is a good thing to do, and shows that you are still interested in them. And again, it's not what you do, it's how you make the person feel. If you make the person feel like everything is done and you really care about, my dad, my mom, my kid, then things tend out a lot better. Of course, there are some times when it is, the wrong place, the wrong time to try to tell somebody that their family died. So trying to do it on the edge of the road is probably a bad thing. I would do it someplace back of an ambulance, over sitting in a cruise or something like that. Someplace where where the person is certainly not in danger, someplace where they're relatively private, and not just like break somebody down right in the middle of a road. That seems kind of bad. Couple of real quick don'ts. Don't miss a chance to be quiet. Silence is fine. If you don't know what to say, don't say anything. A pat on the shoulder will suffice, if anything. But do not miss a chance to not say something, and let the other person do the talking, let the other person react. Don't reinforce denial. Likewise, don't beat a dead horse. You don't have to keep telling him all the stuff that you did and how he's in a better place now. In fact, you probably shouldn't say like, "Oh yeah, he's in a better place." Don't put your views into it at all. Just say you're sorry. If you need to say something, I'm so sorry, and that will again suffice. Don't try to tell him how to feel. Don't tell him it's going to be okay. Don't tell him again he went to a better place, because you don't know how they feel. Just let them do their thing. And don't say that you know how they feel. Even if your mom died yesterday and their mom died today, you don't know how they feel. So just, again, kind of leave your personal stuff out of it. You're sorry, and that's good enough. Don't try to make it okay. And for Pete's sake, don't leave. Don't walk away. At some point, you're going to have to kind of walk off. Leave the person to it. The time when I usually do that is after the person has taken their phone out and made their first call and told somebody else, because they really need somebody to hang out with them, usually while they make that first kind of phone call. After that, it tends to be more okay to go off and do your, tasks, your more technical things. But I'm going to dedicate whatever time that patient's family needs, because that's what the patient, that's the person that I can help. That's what the patient needs. It's certainly okay to be honest. It's okay to do a little bit of touching. I would not initiate touching, but if somebody reaches out and grabs your hand, then let them have it for a minute, unless there's some really weird reason why. Again, silence is fine. You don't have to talk. Nobody has to say anything. It's usually okay to view the body. If it's a coroner's case, looking at mom or dad is probably not going to be any problem. Even touching mom or dad's hand while you're waiting for that confirmation, if this is a more or less expected death, or there's nothing suspicious about it, is probably just fine. I would certainly offer to help. And if you have any questions, medical control call is certainly reasonable. And there are more resources usually available at a hospital than there are available to you in the field. So if you need to call a supervisor, you need to call a chaplain, whoever it is, if you need to call the family priest, that is fine in this case, because we've done everything we can for the patient. Now we got to help those other people that also need us, and that's the patient's family. I'm running over, and I apologize for that, but I do want to say one more thing. I made this analogy before that when we deliver this stuff, when we participate in somebody's death, when we do a resuscitation, it's going to affect us a little bit. It's going to shake us up for a little bit. Most of the time, we're probably going to kind of bounce around and then go kind of back to normal. That's maybe a little bit of a false analogy. I think it's probably a little more something like this. You're going to get hit, and you're going to get hit again, because this is our job. This is the realm in which we function. That's going to happen again and again and again. Most of the time, hopefully, you develop coping mechanisms and you kind of come back to the same place, but maybe not always in the exact same shape, and maybe not always to the exact same place. And sometimes it can really affect you. And it may be the sort of most nonsensical thing sometimes that really sets you off. But there is this expectation that you're going to go back to the station and wash the truck or restock or something like that. And yeah, you should do that. We got to keep doing our job, absolutely. But you do need to take some time. because this is something that doesn't happen to most people. And most of us don't live in a world, we're not designed to live in a world where we see death after death after death and are expected to be okay with it. I do think this is an interesting thing. You may have seen this clip before, and hopefully it works.
You see Dr. Wen in there? He's explaining to that family that something went wrong and that the patient died. He's going to tell them what happened. He's going to say he's sorry, and then he's going back to work. You think anybody else in that room's going back to work today? That is why we distance ourselves. That's why we make jokes. We don't do it because it's fun. We do it so we can get by. And sometimes because it's fun. But mostly it's the getting by thing.
So again, fairly true, rings true to me, only in that, if nothing else, this is not something that people are really used to doing, and it takes some practice. And along the way, until you sort of figure out your coping stuff, that's going to take, especially for younger providers, it's going to take you a while to figure out how to deal with this stuff. And so when you do, you are not alone. You have thousands of people across the Commonwealth of Kentucky, even if you just look at one state, who are in sort of the same boat, because we're all being expected to do stuff that really humans don't typically do. And then expected to just jump right back out there and get back at it. But it is okay to talk about this stuff. And older folks, if you've figured out your coping mechanism, let the younger guys talk. And it's probably worthwhile to do formal debriefings after some of these, and not formal debriefing like we're going to get the whole agency together, but sit down and talk about it. And if you're a shift supervisor, or if you're an officer or something like that, I wouldn't say force this on people, but give everybody the opportunity, because some people won't say it at all. If you're out there and you know that your crew just made a arrest on a 4-year-old kid, everybody's got to sit down and talk about that, man. The debriefing is not, I usually tell people, the debriefing is not for you, the person I'm talking to. It's for your friends. You may be fine with it, but your friends may not be, and they may not know who to talk to otherwise. So we're all at this. We're all doing this weird job where we're again treading on the edge of the abyss, and we gotta watch out for each other. So the last thing I would say is, these are the parts of the job that really make you feel, and the reason that you do the job often, because this is the time when you can actually help somebody, even if you've lost the patient. If they're beyond help, you may be able to help the family at that point, and that's one of those things that makes it worth it. And I'll close with that statement.